Hi, I'm Dr. Jared Gardner, and I'm an associate professor of pathology and dermatology at the University of Arkansas for Medical Sciences. And I'm here with my colleague and friend, Dr. Kent Westbrook, who is a distinguished professor of surgery here at UAMS and has held many roles in his years here, most notably director of the Cancer Institute. And you said, how many distinguished professors are there?
About a half a dozen.
Half a dozen. What does one have to do to become a distinguished professor?
Well, mainly live a long time. No, it's people that have been here on campus a long time and at least in some area have made what was felt to be a significant contribution.
I think you definitely fulfill that.
And it's mostly people, though, that have been here 20 or 30 years.
Okay.
Because the campus feels to make a real contribution here, it takes some time.
Yeah, sure, that makes sense. And you have been here, if I recall, you have practiced longer than any other physician at UAMS, as far as
I
we
think
know?
that's true. I've been on campus since 1961 when I started the medical school.
Wow, and it is now 2019 as of the making of this video, so that's a lot of years.
A lot of years.
And did you grow up in Arkansas?
I grew up in a small town in Arkansas, Clarksville.
Clarksville. And how did you decide to become a doctor?
My dad always wanted me to be a doctor, but I planned to enroll in college in agriculture because I loved farming. My dad ran a fruit research station. And kind of the week or two before I enrolled, I decided, well, I'll just go pre-med. And I never studied about it or thought about it much. It just kind of evolved.
And would you do it again?
Obviously, yes.
So sometimes those small, seemingly random chances change the whole course of everything.
Yeah.
So you came here to med school.
That's correct.
And you said that was 1961.
61.
Right? And then after you completed med school, where did you do your residency?
I did my residency here. Gilbert Campbell had come here as a new chairman of surgery, and I had actually planned to go into OB-GYN. And I started my internship. Back then we called them internships. They were freestanding. And I started my internship. And within a month or two, I realized that I didn't have enough patience to wait for it to go, the cervix to go from 8 centimeters to 10 centimeters and station 1 to station 2.
You're ready to go.
And so I realized that what I liked was the operative part.
Sure.
And Dr. Campbell was a very young, bright, active surgeon. And he came here, and so I was one of the first residents that signed on with Dr. Campbell.
Wow. And then did you at some point work at MD Anderson? Is that right?
After I finished my surgery residency, I went to MD Anderson initially for a 1-year fellowship and stayed on for another year and then stayed on a couple of months to work with a pathologist down there.
Now, who was that?
Gallagher.
Dr. Gallagher. I've heard, because I trained in Houston and everyone spoke about him.
He was a breast pathologist.
Wow.
What was interesting about his pathology, he got involved in whole organ studies.
Oh.
So he would take the breast and embed the whole breast.
Wow.
And cut it on a thing like cutting up bologna. So when you went in his office, the wall would be covered with one breast specimen.
Wow.
And it would be slides that were about this big on the wall.
And
what he was showing was that breast cancer often wasn't just one little focus in the breast. It was more than one focus, and frequently when you did the whole organ stuff, you could see it growing out into other areas. So it was very interesting that he could see different types of breast cancer in the same breast, different foci in the same breast, and connection from intraductal to invasive, etc.
That's amazing. I think that's I've seen some specimens like that, but I feel like very few people know how to do that technically anymore.
And we're probably past that.
Yeah.
It served a useful purpose then. They were studying mainly thyroid and breast at the time.
To kind of understand the complexity of it and piece it all together.
Yeah.
Is that how you got interested in doing breast cancer surgery, or did that?
No, I was already interested in breast cancer surgery, and that I was interested in working in the pathology of breast cancer simply because I liked pathology and I liked breast surgery.
And you told me before, but we'll say it again for those watching. You were in med school and you did some time working in the pathology department.
I did.
Right here.
I did. When I finished medical school, the chairman told me I'd worked 3 years, that I had enough time to count as 1 year of residency if I wanted to go into pathology.
So why did you not become a pathologist?
Well, I jokingly say because pathologists have to spend so much time with their family. Realistically, I wanted to to talk to patients and see patients. So in surgical oncology, you get to see the anatomic abnormalities, and you get to go sit down with the pathologist and look at the slide, but you get to interact with the patient.
I've always really valued that. I mean, I've been here only 7.5 years, but I've loved working with you for many reasons, but I like you have a very holistic kind of view of patient care that's not just technical, surgical, treat the disease, but also I love that you come to the pathology and say, let's look at the slide, show me, when did this cell become invasive, right? You like to ask our fellows that sometimes.
Yeah, I joke about that. Pathology makes a very big point of calling something invasive or non-invasive. And all of these are biological events. And it's not suddenly at 1 a.m. on the first day of the month that something switches from being in situ to being invasive.
Yeah.
And back when I was involved, people were doing a lot of electron microscopy. I don't hear much about that anymore.
It's really kind of gone away, except for medical kidney and a few other specialized things.
They were looking at the basement membrane and the other structures along ducts. And on breast cancer, you could actually see cells that looked like they were in situ that had little pseudopods that went out through the basement membrane and were somewhat invasive.
Yeah.
So I thought that was one contribution that electron microscopy made. I tried to do electron microscopy for a while. And
very challenging.
I never was very successful in getting anything that was worthwhile.
I mean, I think that's, I like that you joke about that, and my fellows always get a little flustered when you ask them, well, are you sure? When did it invade? And I thought it's a funny joke, but it's actually a really interesting conceptual point because, like you said, I mean, when we look at like the edge of a knife, it looks very fine, but you look at high power under a microscope, and it's actually a lot more nooks and crannies in what looks like a very straight line. Same thing we can see a lot under a light microscope, and what looks like a smooth basement membrane is actually much more irregular.
Absolutely.
At ultra high magnification. And regarding melanoma, a friend from Europe was telling me that he thinks that the idea of saying in situ versus invasive melanoma, it doesn't really matter. We should just measure how thick it is, and whether it's a cell in the dermis or in the thin ones are going to be fine the vast majority of the time, and the thicker ones are a problem. And controversial, but I kind of see his point now.
If it's under 0.5 millimeters, it probably doesn't matter whether you see a little bit of invasion or not.
You've seen about how many melanoma patients do you think you've seen?
I've treated probably about 5,000.
Wow, amazing! What an incredible wealth of experience seeing that over the years. How often have you seen melanomas that are thin, like half a millimeter or less, that have ended up becoming metastatic and fatal?
I don't remember any under half a millimeter. I've seen maybe 10 under 0.6 or 0.7.
Yeah, I've not seen 10, but I remember one or two at least that were thin, and I thought, wow, I can't believe that behaved badly.
And I don't think that's necessarily that the pathologist just didn't find the deeper invasion. I think that
some biological differences, right?
Yes. What's interesting about melanoma, I have seen it recur all the way from a month to over 50 years.
50 years.
50 years local recurrence.
Wow. That's amazing. We published a few years ago, from when I was in fellowship, a patient that had a melanoma on the ankle, reportedly like in the 80s or something, and then came back with a nodule of recurrent melanoma. And I can't remember. I guess I should have looked at the paper before. I can't remember the exact years, but I don't know, 18 or so years later. And then that was treated, and it continued to recur, but never metastasized. Yeah. Finally, in the end, on PET scan, found a couple nodules in the lung, sent the patient to treatment, systemic treatment. She didn't do well. Sent her to hospice, and then when I was getting ready, actually I was here in practice, I was getting ready to write the paper up, and I thought, well, let me get the follow-up with the surgical oncologist there to see when the patient died so I could document it for our paper. And he said, I've got a really funny story about this patient. She walked in our clinic 2 weeks ago, had outlived hospice, and said, the only problem she had was another nodule grown up, and it recurred locally 5 or 6 times, but never metastasized. And that was, to me, it wasn't 50 years, but 20 some years. But to me, that really speaks to the fact that microscopically, that melanoma looked terribly ugly. Why didn't it spread? Something must be different about some melanomas that we can't conceptually see with our eyes.
It's different about the melanoma, and it's also different about the patient.
Yeah, that's a good point.
The patient has resistance to it. You see some that rock along 20 years and then suddenly recur and then go wild.
Yeah.
I think that's a lot of patient factor.
So not just the tumor itself, but actually how their immune system and their background.
And if we get melanomas or even squamous cell of the skin in people that have had transplant and they're on immunosuppression. Either one of those can go wild very rapidly.
I've seen some very bad squamous cell carcinomas from immune suppression. So, when you started doing cancer surgery in the 60s, I guess, right? Towards the end of the 60s, what was the standard treatment for invasive melanoma at that point? If you had a melanoma in the extremity, say, what would they do?
What we were taught then was to take a 5-centimeter margin, and we didn't worry. Depth invasion had not really been defined carefully.
Really?
So if it were an invasive melanoma, we took a 5-centimeter margin in all directions, took the fascia underneath because we thought the fascia was a resistance plane to spread, and skin grafted nearly everyone.
Wow.
The lymph node dissection was controversial even then, but for lesions that were thicker, that not measured, but just looked bad, we would do a elective lymph node dissection.
Do you feel that in those days you saw a lot more advanced melanomas, and that maybe the more aggressive treatment was because people were coming in late stage with big nodular
We did
components?
see more advanced melanoma, but the extensive treatment went way back to when people first started defining how to treat melanoma. And some of the first papers were actually based on, not on primary melanoma, but what to do for metastatic melanoma, and then that was transferred over into treatment of the primary. But there were people early on that if a person had a lesion on the leg, they would excise that lesion, make an incision all the way from the primary to the groin, raise flaps, try to take all the lymphatics out.
The whole channel.
And then the lymph nodes from the groin, because the concept of in-continuity dissection became popular for a while.
Wow.
Well, that had terrible complications.
Guaranteed lymphedema, right?
But it required, prospective studies to prove that elective node dissection probably did not alter the outcome.
Wow. Yeah, I read a really great book, The Emperor of All Maladies by Siddhartha Mukherjee, and it was really fascinating to hear his talk about how Halsted and the early surgery, and that they were doing these extensive surgeries and they were so technically precise, but didn't realize that once it's metastasized, no matter amount of surgery is going to fix it.
Yeah.
And so having to see studies that totally redefine the concepts that we hold so true, which I could imagine looking at that when you built your whole career on it, it must be very challenging to accept that what we've thought for so long is wrong.
Yeah.
And I think it's hard for medicine to change because that's mentally difficult to accept. So are there things that you've seen in your career that were difficult, that you've had to totally change your views on as data came out?
I think breast cancer is a very typical thing, For many years, radical mastectomy was absolutely the standard. And the people at Columbia Presbyterian in New York, Hageson and Stout, was that the pathologist, that in 1943 listed the criteria of inoperability, but it was either you did a radical mastectomy or you declared them inoperable and sent them to something else.
Only options, huh?
And they did very meticulous node dissections, and then they did very meticulous examinations of the specimens. They did what they call clearing of the specimens and tried to find as many nodes as possible. So they'd use alcohol or ether or whatever, dissolve the fat, and they would find 40 or 50 lymph nodes. So they thought that by taking out 40 or 50 lymph nodes and looking at them very carefully, they were curing more patients. Ultimately, it was shown that modified radical was equivalent to radical, and that partial plus radiation was equivalent to modified radical. And
was that very controversial, though? Going from that to coming to lumpectomy and radiation, that must have been hard to get people on board with that.
When I came back to Little Rock from Anderson, I was doing some partials plus radiation. There were surgeons in town that believed in the radical so much that if the patient would not have a radical, they would refuse to operate on them and send them out here for me to operate on.
Wow.
Very good surgeons, but they were so convinced that if they didn't do a radical, they were going to kill someone, that they refused to do it.
So even when literature comes out, it's hard for people to adopt it for a while. And I've seen just in my short years of practice, like with the Sentinel lymph node studies in melanoma, that we keep doing these studies that show, well, we don't necessarily improve survival for most patients, but it's hard for people to give up a practice they've done for so long and believed in for so long.
And the most recent thing in melanoma with regard to the nodes is the study that was published a couple years ago, that if people had a positive sentinel node, half of them got a node dissection and half of them did not. The survival is the same, even though 20% of the patients that got a node dissection had additional nodes that were positive.
MSLT, that study,
But the survival was the same. So often, node involvement is just a sign of systemic involvement. But that's not to say we ought to leave positive nodes in. But it's hard to change what you've been taught.
If you had melanoma, would you get a sentinel node?
Yes, if it were thicker than a millimeter, maybe if I were young, thicker than 0.7.
I've often wondered that for myself.
But at my age, though, 79, the sentinel node is probably going to be benign in more cases than it would in a younger
I've heard
patient.
people talk about that in older people, maybe due to changes in the immune system over time, right? That doesn't seem to have as much relevance maybe as...
But I think sentinel node is important, especially as we get immunotherapy that's effective. So sentinel node is not curative, or taking out more nodes is probably not curative, although in some patients it is. But what it does is help us select patients for immunotherapy.
A marker for more advanced disease, and then they need additional therapy.
Additional systemic treatment to try to get at their systemic systemic spread.
So over time, we started with 5 centimeter margins about melanomas and maybe dissecting all the nodes, and we've gone down towards doing sentinel node, or maybe sometimes doing ultrasound and follow-up or something, and 1 centimeter margins around most melanomas, right? So really have
2 centimeters if it's thick,
right?
But 1 centimeter on most. Sentinel node if it's thicker than a millimeter. Maybe not do a sentinel node in older patients, particularly with a head and neck lesion where the sentinel node is more complicated. If you go into the parotid nodes, it makes it a bigger operation. So we'll do a CT of their head and neck, and if the nodes look normal, follow them with ultrasound. Yeah.
What are some changes that have surprised you the most if you look back over your whole career? If you think about things you do and were shocked either when the idea came out, or looking back think yourself graduating med school would have been totally shocked to think of how medicine's practiced now? I know it's a hard question because you gradually adapt to stuff over time, but...
I guess probably the most dramatic thing is what's happened with cardiac disease. Because when I started, if you had a heart attack, you went to bed for 6 weeks.
Wow.
That was essentially the only treatment we had.
Wow.
And then people came along and they thought, well, maybe we can do something to those blood vessels. And the ability to treat cardiac disease, I think, is the most dramatic thing. Cancer has been incremental because at first we didn't have any significant chemotherapy, and then we got some chemotherapy, and then we modified the surgery and the radiation. But heart disease, it's just a dramatic change from going to bed for 6 weeks
to the very complicated, rigorous things that we have now, right? That are algorithms.
Of putting a stent in, sending you home in 2 days, and starting your own exercise.
Wow, that's absolutely amazing. In regards to the cancer, I feel like, again, looking back at some of the history where all these cancers were totally fatal in the early 1900s, and then we started making progress with leukemias, and some cancers we made such progress with germ cell tumors, which we can some of them totally cure, but then we have other cancers like pancreas or brain cancers, some brain cancers where it feels like we've tried so much and made relatively less progress than others. And in a way, it's discouraging, but then I see that, like with melanoma, metastatic melanoma used to be essentially a death sentence, right? That was when I was just 10 years ago in training, and now with checkpoint inhibitors and these new drugs, that's significant, 20 or 30% of people we think might be able to be
long-term survival. And of course, Jimmy Carter is the example that everyone points out.
Sure.
As far as I know, he had brain metastasis and liver metastasis.
Unbelievable.
And had surgery and radiation and
he's in his 90s?
He's in his 90s.
Amazing. Yeah, so that gives me hope that maybe just in 10 years we made this huge leap. Maybe we'll eventually get there with some of these other cancers that seem to be hard to cure.
The brain is terribly difficult because it's hard to get drugs there.
The barrier,
it's in a contained area. If it grows, it produces so many symptoms so fast. The pancreas is kind of the same way. It's hidden in the retroperitoneum. It's hard to know anything about it before it gets significant. The surgery on it is difficult but doable, but only in a small percentage of the patients. So there are some organs that are very difficult still.
And what do you think about cancer screening as a whole? In medicine, I was always taught cancer screening is the best thing in the world, and we should all be doing it because obviously the PAP and things like that have made huge progress, and we've detected cancers earlier. But I've also heard some people argue that maybe screening helps us detect a lot of things that would never cause problems anyway, and that caused some cognitive dissonance for me because it goes against kind of the religion that we have in medicine that screening is good. What do you think, having seen screening over your whole career?
Well, if in medicine we did screening of everything that every specialty wants, if we measured eye pressures, if we measured blood pressure, if we did everything that every specialty wants, we'd be doing an enormous amount of screening. Now, cancer, where you're trying to detect a fatal disease, is a little different. And Papa Nicolau had a hard time convincing people that what he was doing was worthwhile.
Wow, amazing.
He went on a tour across the country to try to convince. And so it took a long time to convince people that you could just take a little smear off the cervix and tell what was going on. But clearly on cervix, early detection was easy and reliable, non-expensive, non-invasive, so that was
seems like
good.
No doubt that has changed things dramatically.
Now, on breast cancer, mammography is a good screening test and picks up cancer earlier than we would pick it up otherwise, and apparently has contributed to the increased survival. Now, 80% of women with breast cancer are cured or have a long-term survival. On melanoma, the cure rate is 80%, not because our surgery is any better, and not really because of immunotherapy. It's because patients come in with thinner lesions, and they do it because they've been educated and their doctors have been educated.
Growing scary brown spot, go to your dermatologist.
But then when you get to complicated screening, like the spiral CT scans for lung and for prostate for a while, we were doing the PSAs and the rectal examinations and colon. When you say colonoscopy, the more complex screenings are harder to get patients to accept and to justify. But I do think with screening, we detect earlier disease.
Sure.
So it can make it look like we're doing better than we actually are.
Right. It makes it harder to look at the numbers, right? Because we see more cancers and they're earlier, and so of course we're going to have a higher percentage doing better.
So how much screening should we do? I really don't know. I think we could, if we screened, for all the diseases we can screen for, would be wasting a lot of time.
We come to the doctor's office every day, right?
Yeah, there are people who say we ought to screen for Alzheimer's by doing many
mental status
exams on a regular basis. And we ought to screen for aortic aneurysms by doing ultrasound on a regular basis. I'm not enthusiastic about these companies that go around and do screening things for profit, where they come in and they do arterial screening on the neck and on the leg and aneurysm screening and all that. And then if they find something, then you work it up.
It's a little conflict of interest right there.
I'm not enthusiastic about that type of screening.
Sure. What accomplishment in your career are you most proud of?
Well, I would say probably the Cancer Institute here, because we really started from scratch and built buildings and recruited people and have a very viable cancer program.
When was that it started?
1984.
And so before that, there was no cancer center in Arkansas?
No. Dr. Sun and I started working together in 1974 when he came back from MD Anderson. And we developed a head and neck cancer demonstration project that was federally funded. So it was a multidisciplinary head and neck project. And we built a head and neck program. We actually could not get beds in the university hospital. So we rented beds in an old Baptist hospital that was across town. They had moved out and we got some beds in it. So we started the head and neck program there, and that was kind of the beginning of the cancer center. Wow. And we did that for 8 or 10 years, and then Dr. Harry Ward, we convinced him to do a cancer center. And we raised money and built part of the cancer center. We underestimated the space we needed, because that was about 1989, I think, when we moved in. Cancer chemotherapy was changing from inpatient to outpatient.
Oh.
So we did not have nearly enough outpatient capability for cancer treatment. So when we first opened the cancer center, we had 4 floors in what's now the Walker building. Within a month or 2, we had outgrown the space.
Wow.
So what we did, we went to Texas and found some dentist that had a couple of double-wide trailers that he had made into dental clinics. And we bought those and moved them here and set them up on the parking lot and converted them into medical oncology clinics. So we had double-wide trailers as our medical oncology clinics at the time.
What a leap now to the beautiful, enormous building that we have, and all the space and all of the really complex level of care. What an awesome accomplishment.
But Dr. Hutchins was willing to move into the trailers.
Wow.
And she's always been a wonderful person.
That's
great.
great.
She was willing to move into the trailers and let the multiple myeloma people have the new clinic.
Wow. That's one thing I'm not from Arkansas. I just came here out of training, and I've been so impressed by the collegiality and how everyone works together here and to provide just like world-class service to the people of Arkansas. And I love getting to be a part of that. It's really cool. Very special.
I think people here want to see other people succeed.
Yeah.
There are places where people seem to feel better about themselves if they see someone else fail.
I have heard that.
That's not the way you feel better.
No,
you
it's
feel
terrible.
better by everybody doing better.
You lift people up, and then it elevates you. Everyone wins. It's not that hard.
When you pick someone up, it makes you feel better.
Yeah, absolutely. What advice would you give to a first-year med student entering med school today about how to be an excellent physician?
Well, I think one thing, they have to learn to communicate.
Mm-hmm.
And that's more than just get the data and tell it to the patient.
Mm-hmm.
I listen to some of the younger people talking to patients, and they don't talk in a language that the patient can understand. So I think they've got to learn to communicate. I think they have to recognize that there are all sorts of disciplines in medicine, and they have to work together. And there's not one discipline that's the key to everything. Certainly pathology and radiology cut across all the clinical specialties. So they've got to have an appreciation of those 2 specialties, and I think they need to learn to look at slides with pathologists and look at x-rays with radiologists, and not just read the report and highlight it.
Right.
So I think that's important. I think learning to work with other specialists, other doctors, and with other healthcare providers is important.
That's good.
They need to learn to be continuous students. Now, most of them know that because they use the telephone so much to look up information. So whether they want to be continuous students or not,
They are.
They are.
Yeah.
That's just the way it is. But there was a time when people would train and go out and practice for 20 years and not change anything that they'd learned.
Wow.
Because they thought they learned the way to do it.
Wow.
Now I think the students realize that things change fast and they look up information.
Yeah, in a way, I guess that's good. That's the way, like my kids and the generation of our students now, they've grown up with smartphones and internet and being able to, we don't have an answer, I'll find it. I just look it up, right?
On the other hand, they may not have as much basic knowledge.
That's true.
You know, for example, if I asked a resident, tell me the branches of the abdominal aorta, they haven't memorized, that there are 3 anterior and 3 laterals that are paired, and this is what they are, because they can look it up and get a picture of it in 5 seconds.
I think telephone numbers are a great example. I know maybe 2 or 3 telephone. I mean, I know less than 10 telephone numbers in my head because I don't need to know it because I have access. You could argue that frees my mind up to focus on other things, but it certainly has changed and shifted the way we think about knowledge and access knowledge and retain knowledge now than in the pre-digital age, I think.
And we also lose some skills because of it.
Sure.
There was a time when I could take a column of numbers and add them up in my head pretty well.
Wow. No, I cannot do that.
And now
I have to
use a calculator, and then I have to go back and repeat it because my finger hits the wrong key.
Do you have a smartphone with a touch screen, like an iPhone or an Android?
Yeah.
When did you finally adopt that?
Oh, it was fairly early.
You're an early adopter. That's good.
I did initially. I said no, but then once I adopted it, and I think now that I'm on some kind of instrument 2 hours, 3 hours a day.
Sure, and it's like just the modern world,
It
right?
embarrasses me when it comes out and it says, you've been online.
Oh, your screen time? Yeah. Well, I mean, I just think it's like this is the new normal, whether we like it or not. This is the new, and we have to find a way to adapt to it and use it for good, right?
And I find myself in conferences when something comes up and I can kind of remember it. I'll pull my phone out and look it up.
Yeah. That's what I do too. I'm like, what was that thing I heard? And it's nice. You can pull up the literature, PubMed, and you know, one of my mentors, Sharon Weiss, she was telling me how she first wrote her soft tissue sarcoma book, and she took a typewriter to the library and pulled out. And I just thought, what a fundamental difference in the way that now we just pull up and cut and paste from the literature and reword, and different world.
When I was in medical school, I actually wrote notes for our class for physiology the first year and pathology the second year. And so I would go in and take notes by hand, and then I'd go out and get on a typewriter, a mechanical typewriter, and type them. And I would type them on the blue stuff that you then put on a...
Oh, carbon copy?
No, not carbon copy. Mimeograph machine.
Oh, I've only heard of that. I've never seen
it was a
one.
blue stuff, and when you hit it, it cut a hole in it.
Oh.
And you mounted that on a machine and turned the handle, and it threw ink through those places that the typewriter had cut.
Wow.
And you could had a little pen, a stylus that you could draw figures. We would have to type it, illustrate it with hand-drawn figures, put that on a machine, turn it, put ink in it, turn it, and that was the way we printed off notes.
And so when you published papers in the literature, I imagine that was quite different than today too. You had to type it up and take photographs that you developed from film and wow.
And initially when in conference when we showed slides, we used what were called lantern slides, which were about this big, and to actually, those were projection type slides. When we actually showed specimen slides, we had a machine that you had an arc in it. You fired an arc up and you put the slide in and it would kind of project it on a screen.
That's cool.
But as time went by, we learned better and better techniques of illustration, and now it's absolutely amazing to me that you can sit down at a computer and what you can do.
It is. It's crazy.
I teach Sunday school, and I spent about an hour yesterday on the internet pulling pictures off and illustrations off. And in an hour, I had prepared a 30-minute presentation with slide illustrations and all that sort of stuff. Absolutely amazing.
Pictures of anywhere on Earth from every different angle. I did a teleconference webinar with a team that in London the other day over the computer in the morning, and then I finished my work day. And it's and now it's just commonplace to do that. And what a change. Would you do anything differently in your career if you could go back and do it again?
Oh, I think that if anyone tells you they would not do anything differently, you have to think they haven't learned anything.
That's a good answer.
As far as major things, I would still probably do the same things.
That's wonderful.
I can remember a patient or two, though, that I made a mistake on, and if I had those to do over, I would do them over. I can remember some things in my personal life. You know, it's easy for doctors to think they're smart. And they think if they're smart that they can get into the business world and make a bunch of money. And I got into a couple of business things and lost money, so I would probably not do those.
Yeah, I've heard that it's because we're good at other things, we think we must be good at everything, and that's a kind of a fallacy logically.
One of the phrases that people use is generalization of expertise. You think if you're an expert in something, that you're an expert in everything, that you're smarter than other people, and you can do better than they can.
Yeah, that's a good point.
I was involved in an investment banking firm and was one of the managing partners.
Wow.
That we bought from New York and moved to Little Rock.
Wow.
One day they called me and they said the NASD, National Association of Security Dealers, has shut us down. And I said, what's the problem? And they said, well, our books are out of balance. And I said, how much? And they said, 400 million. Well, we only had capital of $1 million. So, but once it settled out, it was 200 million on the buy side and 200 million on the sell side. But it was enough that it shut us down and destroyed our company because we lost our credibility.
Wow.
So credibility is important to keep in medicine or in business or in personal relationships. So you've got to have your credibility.
How do you keep credibility professionally?
Being honest.
Being honest. own
being
up
honest.
mistakes, I guess,
Yeah.
and
Accountability, owning up to mistakes. I think that surgery in general across the country has a very good tradition of mortality and morbidity conference, M&M conference.
What happened?
Where you go in and you say, what happened and why did it happen? Did it happen because I cut wrong, or I thought wrong, or I didn't follow up on the patient? So I think surgery teaches accountability in medicine probably better than any other discipline.
Yeah, I think that's so important, and it's a sad thing that in the fear of legal issues and stuff there's a tendency to be afraid, and I would love to see, and I know the tide's starting to turn, but getting towards a way that we can all be more open about mistakes, because we all will make mistakes and there's no way to avoid that, but we can learn from other people's mistakes. Some of the greatest lessons I learned were things that my mentors, who I look up to as better than I'll ever be, said, this one time I thought this and I was wrong, and it wasn't that. And later in practice, I've seen a case and I thought, I wonder if and sure enough, that story they told me spared me from harming a patient.
Yeah.
And so I was so grateful when senior experienced people share their mistakes, because it shows us we're all that way.
I think the fear of litigation is real. Well, the fear is obviously real.
Sure.
Litigation is less real. Mm-hmm. But then, I'm convinced if you're honest with patients that they will accept a lot of mistakes.
Sure.
Over my career working with residents, there I guess I'm blaming residents a little bit, but only 4 of my patients' sponges were left in. Mm-hmm. So I had to go in and tell the patient, you've got a sponge left in and we've got to take it out. None of those patients ever sued us. I had good relationships with them. I told them we've left a sponge in, we're going to take it out, it should be okay. Now, they could have gone to a lawyer and we would have settled, because you can't defend
a mistake, sure.
You can't defend leaving a sponge in. But they did not.
Maybe it goes back to what you said about credibility and relationships. Nothing changes the need for that between humans. Right. That when you are honest and real with people and respectful, it's always possible someone's going to be mad and do something, but most people are normal folks and realize that we're just doing the best we can to take care of them. And
relationships with other people are very important. Now, I realize in the business world they just use statistics at times, but in medicine, relationships are critical, and in life, relationships are critical. I was reading a guy yesterday, and he was saying, what are the things you're going to think about when you're ready to die? Are you going to wish you'd done a little more, read a few more slides? Or are you going to
written one more paper or something?
One more paper, or that you had one more plaque to go on your wall? He said, no, that what you're going to think about are the relationships you have with people.
Yeah. I am really lucky that I'm married to an amazing woman she's a psychiatrist, but even before that, she just really has a lot of wisdom about life. And early in my career, she told me that, and maybe when I didn't want to listen, but said, so a lot of people are successful, and at the end of their career, they look back and realize they burned all the bridges along the way, and they've got everything maybe, but they're not happy. And so I really took that to heart, and I worked that even though it's hard early in your practice and you're busy, but I try to make time for my family and my friends and make time for relationships. And I feel already very happy with that. And I feel like that's what I will value in the end.
And you're lucky in that you chose a discipline, pathology,
that
lets you to do that a little more than some other disciplines do. You're lucky in that you've learned to use social media so you can have friends all over the world.
That's true. It's really enriched my life.
I enjoy following you on Facebook, although I never respond, but I enjoy seeing your family and seeing the food and seeing where you are and what's going on. So you're lucky in many ways.
Well, good. I consider
now, there'll be times in your life when you won't be lucky.
That's
Things
true.
will happen. And you have to just suck it up and handle them.
I'll do my best to do it. Thank you so much for sharing your wisdom and your
Thank
stories.
you, sir.
I really love working with you, Kent. Thank you.
Thank you very much.